My name is Monika Osko. I would like to thank the Magnus Conference organizers for inviting me for today's lecture. I would like to present the short presentation that will be about 20 minutes, and then immediately after that, the workshop. So don't go away. I hope you will be enjoyed. The MFS philosophy, a causal approach to craniofacial growth and development through myofunctional stimulation. That will be the first topic. And also during that short 20 minutes presentation, and I also would like to present you some unraveling the effects of delivery mode and lingual frenulum on neonatal sucking strange, a discussion of research findings that are part of the international research project conducted by two universities, Barcelona and also Wrocław University. So as you know, my name is Monika Osko. I am graduate of Medical Academy in Poznań, awarded with the University Medal, Master in Orthodontics, University of Siena, currently pursuing a PhD, founder of the Polish Society of Myofunctional Therapy and organizer of two international conferences under this association, lecturer at Orthodontic World Institute, 11 years leading the MFS modular training. 17th edition starts this Saturday. And co-author of the book with Professor José Durán von Arx, titled Orthodontic Treatment According to MFS Philosophy, a causal approach to craniofacial growth and development, simulotherapy. I have 25 years of professional experience in orthodontics and creator of a tool for myofascial release technique, an innovative approach to orthodontic therapy, not only orthodontic, but also for myofunctional therapy. And this tool, I would like to show you to present some cases, how it works. My interest in function therapy focus on function, analyze how craniofacial structures develop from a very early age and how they impact patients' health, as well as the factors influencing the quality of these functions. In my scientific and also clinical work, I place particular emphasis on functional therapies just to support the natural development of the stomatognatic system and to ensure the best long-term results for my patients. The foundation of my scientific exploration, it is the philosophy of created and developed by the Professor José Durán von Arx. It is rooted in functional diagnostic and therapy also. And I'm focused very much on orofacial functions, muscle balance, and also breathing. There are three pillars of simulotherapy according to this MFS protocol. This is the breathing, just restore nasal breathing as a primary function, then swallowing, correcting dysfunctional swallowing patterns, and the mastication to ensure proper chewing and tongue posture, and functional diagnostics according to the MFS protocol guide personalized therapy plans. So this is a Professor José Durán von Arx, the president and founder of the Orthodontic World Institute, for many years the head of the orthodontic department at the Barcelona University, author of many books and also of the articles. And this book we wrote together. And it's awarded for many associations for the simulotherapy devices, as you can see here, dedicated for the patient of dolichocephalic type of growth and also for the brachiocephalic type of growth, and also awarded for the torque individualization. The simulotherapy concept, it is because the process of the facial growth and development depends on the brain as the superior control organ, and genetically programmed reactions and reflexes serve as the foundation of the oral facial motor skills. And MFS stimulators act by engaging proprioceptors and mechanoreceptors located in the muscles and the periodontal receptors, and they improve the development of the whole craniofacial. The cranial nerve stimulation are essential for improving the oral motor functions, and cranial nerves play a fundamental role in sensory-motor regulation in the orofacial region, and their activity is influenced by proprioceptors. The proprioceptors are specialized sensory receptors that detect changes in muscle tension, stretch, and also the pressure. And I would like to show you one case we treated with them with this stimulators. This is the girl with the brachiocephalic, with the dolichocephalic type of growth because of the mouth breathing, the tongue, low tongue position, and also dysfunction of the masseter's muscle because of this weakness of the masseter's muscles. It is because she's breathing through the mouth. And as you can see, she's class 3 dental, and she's also class 3 skeletal. And to restore these functions, we use this. This is a different patient, but just to show you how it is placed in the nose and also in the mouth. As you can see in the mouth, she's contracted. The orbicularis muscle is contracted because of that stimulation. And after some period of using those stimulators, you can achieve the good results. As you can see, after the 4 months of progress of restoring breathing functions and also the tongue positioning, you can see that we have the edge to edge after 4 months. And on this picture, you can see that how she looks like after 1 year of treatment, of using the restoration of the nose breathing and also to improve muscle functions and to stimulate the trigeminal nerve, which is very important in that functions, to use only with those 3 stimulators: nose stimulator, mouth obturator, and also open bite device, just to stimulate the proprioceptors located at the roof of the teeth. So, and also to stimulate the proprioception located at the palate and also proprioception located at the tongue. And the special approach how we diagnose the tongue, I show you just a little because the all modular training, it is the 5 days of course. You can see the result on that girl after 1 year. You can see the open bite. We had the open bite class 3, and now we have normal bite. And when the X-ray photo before and after, and then on that X-ray, you can see the improvement in skeletal. This figure comparing lateral skull images before and after 1 year of therapy with the MFS stimulators, and whose the primary effect was altering the breathing pattern and strengthening the masseter's muscle. And restoring normative function allowed for change in the growth direction. As you can see, she has the open angle, open goniac angle. She has the now she has the better inclination of the upper incisors. She improved in the dimension of the anterior posterior, and she improved the lower third of the face. The muscles of the orofacial region control the growth direction of the chondrocranium, which is located at the base of the skull and which is the one of the independent growth center, as well as the vertical dimension of the occlusion. And after 3 years and 4 months following control of how this girl is growing, you can see that we have a good occlusion. But what is very important, we just checked how it looks like the upper griddle. If we have some deviation here, we know that something can be wrong and inside the mouth or in the posture. So this is why we cooperate with the physiotherapist. And this approach is also to show you that the dentist, orthodontists, they don't have so much time to treat the patient with those functional disorders, but they can cooperate with the physiotherapist, osteopath, and also neurospeech therapist. This is the approach for the neurospeech therapist also. When we see this, also we refer patient just to the physiotherapist. And if you see that something is wrong with the mastocranial mastoideus muscle and the upper girdle is deviated, we also refer patient. But we also, what is very important, we check how the tongue is working, because when I will show you maybe later, when you will see on the video, you will understand maybe better my what I am thinking of. The muscle pattern influenced on vertical overbite, mandibular angle, arc width, facial height, and even facial width. Studies made by Kyriaridis show that muscle tension in the maxilla and the mandible can extend to the extraocular muscles and cranial value. But not only the studies of the Kyriaridis, but there are the studies made by 1973 by Mayer and Baron, and they discovered that this homolateral pathway from the trigeminal nerve, and trigeminal nerve, it is connected to other cranial nerves, the third, fourth, 6, and 11. And the cranial nerves, they also are combined with the spinal nerves. And this is a very important, this cooperation, because we can create the better growth for the patient if we know how it is connected together. And the vertical dimension of the lower third of the face depending on the muscle pattern. And if we have some complication, those patient I show you, this girl, she has the dolichocephalic type of growth caused by mouth breathing and all of the chain of the dysfunctions because of this mouth breathing. And now I would like to show you some other case. This case is brachiocephalic type of growth. When the patient has increased muscle tone at the masseter's muscle, and when they sometimes have some habits or they have some interactions between tongue, lip, tongue, teeth, and they just make some not only habits but parafunctions also, they interact these muscles which are forming the buccal ring, the orbicularis muscle, buccal muscle, and also superior pharyngeal constrictor, which is connected to the pharyngeal tubercle on the occipital bone. When it is deviation, when it is the not proper working, we will have some problems with the inclination of the upper lower incisors, as you can see in that patient. And in that patient, you can see that is class 2 division 2, and we also can notice that there is a deep bite. There's a brachiocephalic type of growth, but we also make the diagnosis of the tongue elevation. This is very important for us. We are crazy about the tongue function, about the tongue position on the palate, the resting position. And as you can see, this tongue is deviated to the right. I will later show you at another case how it is important to check the deviation of the tongue or check the resting position on the palate for the patient. What we made the approach focused on functions, and also we put the orthodontic braces with torque individualization. We just individualize what kind of torque it is needed for that patient on the lateral X-ray, and we also implement some stimulotherapy. In that particular case, we give for the patient the anti-bruxismus device. Anti-bruxismus device, it is opposite, because if we have hyperactivity at the masseters, teeth contact too often. If they contact too often, they put the information not only they put the information for the trigeminal nerve. The trigeminal nerve, it is very important because this information goes to the brain, and brain recognize it is too often stimulated. And when it's too often stimulated, the reticular system inside the brain cannot make filtration and gives the signal for the other muscles. And then we have some problem with the posture, and also we have overaction of these masseters. So what we have in this patient, we have, you can see what kind of growth we have, the brachiocephalic type of growth with the retroinclination of the upper and lower incisors. So we use the torque individualization, and also we use anti-bruxismus device to worn at night and some hours a day, and also the tool. The tool I designed, and I will show you, I have those two, this one and also the another ones, 0.5 newtons, 1 newton, and 1.5 newtons, just to check what kind of pressure you can use just to simulate the fibroblast composing the area when we want to stimulate. So you can see the improvement when we unblocked the potential of growth, because this patient, he was in a third spurt growth, the somatic growth. And somatic growth, it is combined with the mandibular growth also. So we unblock the upper incisors, so mandibular can grow anteriorly. And as you can see, we also have not only changes in the lower third of the face, but we also have the changes of the skull, and we have the changes in the posture of that patient. And as we are crazy about the tongue, so we check what is the position, because when we just want to improve the tongue function, that we check how it works during our restoration of that function. So he has the nice position, resting position on the palate, and this is also very important to achieve long-term results. And you can also use the anti-bruxismus device, not only with the braces, but also for the patient 4 years old, 5 years old, and also in the teenagers. As you can see in that girl, just check this, the muscle balance, right and left side of her face. And we can see there is the imbalance in the muscle. We check how she chew the right side and the left side. We check the tongue elevation, and we saw there is a very many difficulties. So we put her, she's also grinding the teeth during the night. So we put her the anti-bruxismus device, and we just use also the tool for the myofunctional release technique for her tongue, and also for the floor of mouth fascia. So according to MFS philosophy, the breathing is the foundation of orofacial functions. And step 1 is to restore nasal breathing, because it is impossible to normalize the atypical swallowing or weak masseter tension without restoring the primary function, which is the nasal breathing. So ensure proper oxygenation and craniofacial development, because when we breathe through the nose, the air goes to the sinuses, and sinuses, inside sinuses, there is the resorption and apposition outside the sinuses. So this is why we have the growth also of the bony structures of the nose breathing. And it eliminates compensatory mouth breathing habits and change neurological integration of orofacial reflexes. And step 2 is to normalize swallowing pattern. Swallowing mechanisms depend on a stable airway, and functional tongue posture guides dental arch growth, and proper deglutition prevents malocclusion. And step 3 is to optimize muscle tone and orofacial balance and muscle strength and coordination to ensure long-term stability. And masseter activation reinforces correct jaw positioning, and functional adaptation depends on continuous stimulation. And MFS philosophy, it was a turning point for me, and I inspired by this philosophy, I have focused my research on the relationship between tongue functions and the growth of oral structures. And we did the study to unraveling the effects of the delivery mode and lingual frenulum on neonatal sucking strength. And we did a prospective study, and I was a leader in that project. And this is the picture with the Professor Duran and also with the Professor Usra from Barcelona University. And this is the picture with my colleagues who helps me with that project. And also you can see the little newborn, which is a part. The 154 children was a part in that study. The importance of neonatal sucking strength. It is a key factor in oral development and feeding efficiency because the first year of age, it is the first growth spurt in the human, for the humans. A key factor in oral development and feeding efficiency and impact on breastfeeding success and orofacial growth, and it has a role in the lingual frenulum, diagnosis of ankyloglossia, association with feeding difficulties, and we want to check also the impact of the liver mode, differences in proprioceptive stimulation at birth, and possible consequences for tongue functions and ankyloglossia assessment. And the study objective, it was to investigate whether the mode of delivery, the natural birth and cesarean section has influenced neonatal sucking strength and analyze the relationship between intraoral vacuum, not vacuum, but intraoral value, pressure and lingual frenulum function, and evaluate the hypothesis that neonates born via cesarean section generate lower intraoral value. And this study was conducted in Centrum Medico-Użyckie in Lubań, Poland, and also in dental practice in Poland also. And measurement tool, it was Iowa Performance Instrument and Alison Hazelbecker as a Hazelbecker assessment tool. And the Iowa IOPE instrument is considered the gold standard for assessing tongue strength. And purpose of Hazelbecker ATLF scale, we check the morphology and also functions of the lingual frenulum. And you can see the little baby where is sucking this balloon from the IOPE. And the neonates delivered vaginally, natural birth. The mean intraoral value, it was 14.5 kilopascal, and neonates delivered by cesarean section, the mean intraoral value, it was 12.4 kilopascal. So this is statistically significant difference in that two ways of birth. So neonates with lower ATLF scores exhibited reduced tongue mobility and intraoral value lower than 11.5 kilopascal increased the likelihood of frenulotomy by 6-fold, and no significant difference in ATLF score between the delivery group were found. So statistical analysis using these methods, and I would like to show you also the short video of the cesarean section. And as you know, the natural birth, it is about 8 hours, 10 hours. As you can see, this cesarean section, but it is especially elected cesarean sections. It is about 12 seconds, as you will see from that video. And you can see also how the head is manipulated by the operator hands. It can be dangerous. It can cause the kiss syndrome. So the cesarean section can be considered a form of sensory deprivation for the newborn, that during the natural birth process through the birth canal, the baby is exposed to numerous mechanical, proprioceptive, and tactile stimuli, which constitute some of the first sensory experiences stimulating receptors and supporting the development of sensory motor patterns. And these key stimuli play a crucial role in developing adaptive and integrative mechanism. So cesarean section may limit sensory experiences, crucial for the newborn's ability to build sensory models of the environment, potentially leading to the disturbances in sensorimotor integration and the development of qualitative spatiotemporal organization in the cerebral cortex. So this can impact oral, gustatory, and adaptive functions, reducing responsiveness to stimuli. Natural births support early brain development, and its absence may have lasting neurological effects. And here I have the short video also to show you how the baby with the ankyloglossia move the tongue. If the range of motion of the tongue is restricted, but like in that case, for example, by this frenulum, yes, you can see that the tongue is restricted. The dynamic stretching of fibers is reduced, so dynamic stretching inside the tongue is reduced, leading to a decrease in the number of active cross bridges and a weakening of the potential contraction force of the tongue. So in that first year of the child, this is a very important, the sucking force, the force of the tongue, how it is created the interaction between the cranial nerves, but it is also improved the development of the craniofacial of the cranium of the occlusion in the future. Such a situation may occur in cases of ankyloglossia as well as in cases of mobility restrictions resulting from factors affecting the dimensions of the fascia structures of the oral floor and tongue. And these restrictions may stem from tension limitations within the fascia itself and a reduction in the formation of transverse bridges in the structure of striated muscles that compose this area, which are not related to ankyloglossia. As the conclusion, neonates born via cesarean section have reduced sucking strength. Prospective stimulation during vaginal birth plays a role in oral function development. A risk of overdiagnosis ankyloglossia in cesarean-born infants. A need for a true assessment before considering frenulotomy. Study demonstrates that neonates born by cesarean section generate lower intraoral occlusive values during non-nutritive sucking, and this finding suggests that reduced proprioceptive stimulation at birth may impact neonatal oral functions, contributing to the misclassification of ankyloglossia and unnecessary surgical interventions, because as you know, there is a very big increase of the diagnosis of ankyloglossia, 420% more than before. So, and it is also very much increased of the cesarean section delivery. In some countries, this is 60% of the birth nowadays. I sincerely thank my co-authors for their valuable contributions to this research, and thanks mothers and childs for taking a part in that research. A clinical implication, a guidance for the clinicians is to consider the delivery mode in ankyloglossia evaluation, avoid unnecessary diagnosis and intervention, need for long-term studies on delivery mode and tongue function, evaluation of myofunctional therapy for improving neonatal sucking strength, and developing better diagnostic tool for accurate ankyloglossia classification.